بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. I will talk about the tumors of the middle ear and cochlear implants. Glomus tumors, Glomus tympanicum and Glomus jugulare, they are the most common benign neoplasm of middle ear and are so named because of their origin from the glomus bodies or glomus cells. Glomus bodies resemble carotid body in structure and are found in the dome of the jugular bulb or on the promontory along the course of tympanic branch of glossopharyngeal nerve and is called Jacobson's nerve. We have Glomus tympanicum, which is found over the promontory and arise from the tympanic branch, which is called Jacobson's nerve of glossopharyngeal nerve, and Glomus jugulare, which is found at the dome of jugular bulb, which is present just underneath the floor of the middle ear. Glomus tumors consist of paraganglionic cells derived from neural crest. They can cause local destruction by gradual growth and are very vascular. Clinical features of glomus tumors are pulsatile tinnitus, which is characteristic of glomus tumors, and conductive deafness, and in larger tumors, the cranial nerves exiting from the jugular foramen may be involved, like glossopharyngeal, vagus, and accessory nerve, associated with pain, and this is called jugular foramen syndrome. In glomus jugulare, in glomus tumors, we see a red mass behind the drum arising from floor of the middle ear, and this is called rising sun or setting sun sign. When tumor present as a polyp, examination reveals a red vascular polyp filling the meatus. It bleeds on manipulation or at biopsy. So biopsy is contraindicated in glomus tumors. Why? Because they are highly vascular and biopsy can cause massive fatal hemorrhage. This is called rising or setting sun sign. We see a pulsatile red or bluish mass behind the tympanic membrane. سموها rising or setting sun sign تشبه الشمس في شروقها وفي غروبها. So, how can we diagnose glomus tumors? If the biopsy is contraindicated, we should do CT scan of the temporal bone with a contrast study to see the vascularity and the extent of the glomus tumors. Treatment may simply by observation if the tumor is small, since they are very slowly growing. Surgical excision may be required in larger tumors with preoperative embolization for shrinkage and regression of the tumor prior to surgery. If surgery is inoperable, surgical excision is inoperable, or for regression or residual tumors, we use deep X-ray therapy. The most common malignancy of the middle ear is squamous cell carcinoma, and the clinical features of squamous cell carcinoma are chronic foul-smelling blood-stained discharge, deep-seated pain, facial nerve paralysis, with history of chronically discharging ear in 75 to 80% of the cases. During examination, we see a friable, hemorrhagic granulation, or a granular polyp filling the meatus. So if we see a polyp or hemorrhagic granulation tissue in the ear, rising from the middle ear and filling the external auditory canal, associated with otology and bloody otorrhea, plus minus facial nerve paralysis, so we should exclude the malignancy of the middle ear. How can we diagnose this? We should do CT scan with contrast study to exclude the presence of glomus tumors. After that, we can do biopsy from the mass and send for histopathological examination. But prior to that, we should exclude presence of glomus tumors by CT scan of the temporal bone with contrast study. Treatment of squamous cell carcinoma of the middle ear by a combination of surgery and deep X-ray therapy, which gives better result, although the prognosis is poor. Cochlear implant. A cochlear implant is an electronic device that can provide useful hearing and improved communication abilities for persons who have bilateral severe to profound sensory neural deafness and who cannot benefit from hearing aids. And the cochlea should be normal in its structure. The cochlear implant consists of two components. The external parts consist from microphone and speech processor and the transmitter, while the internal or implanted components consist from the receiver, stimulator, and the electrode array, which is inserted inside the cochlea. The function of the speech processor: the microphone collects the sound, and the speech processor processes the sound and codes them, which means converting the sound into digital signals, and then fed to the transmitter, and the transmitter sends the digital impulse through FM frequency into the receiver stimulator, which is implanted under the skin. These are the external components: the microphone and the speech processor and the transmitter. The transmitter attached to the implanted part to the receiver stimulator through magnetic couple, Here we have the external component, speech processor and transmitter, the implanted portions, the receiver stimulator, and the electrode array, which is inserted inside the cochlea and take the configuration of the cochlea. Here we insert the receiver stimulator inside a wheel which is drilled in the outer cortex of the skull behind the mastoid cavity. And here we have posterior tympanotomy. This is the posterior tympanotomy, and we do a fenestration or a hole just in the wall of the anterior part of the round window, just in front of the round window opening. We make a hole to insert the electrode array inside the cochlea. This is the mastoidectomy with posterior tympanotomy, and here the electrode array inserted inside the cochlea. It is like a spring and takes the configuration of the cochlea. It has multi-channels, multiple frequencies, and each part is responsible for certain frequencies. So the part inside the lower part of the cochlea is responsible for high frequencies, and then the middle part for the medium frequencies, and the upper part responsible for low frequencies. Here the cochlea and the electrode array bypass the degenerated organ of Corti and the hair cells and stimulate the cochlear nerve fibers. And then the electrical signals transmitted along the cochlear nerve to the auditory cortex. The patient may have excellent hearing and can even conduct conversation over the telephone, but the best result achieved in cochlear implant by the cooperation of the family of the patient with the audiologist and speech therapist. Good luck.